Thank you very much. It's a great pleasure to be here, a wonderful place, and thank you all for joining us today. We're going to talk about the JAK2 inhibitors, completely different topic than chronic myeloid leukemia and TKIs used to combat BCR-ABL. Let's go heads on the topic and describe what we are talking about here. As you very well know, JAK-STAT signaling is part of the normal hematopoiesis, blood making in the body, but also part of inflammation and immune function because there are four members of the JAK family, JAK1, JAK2, JAK3, and TYK2. And importantly for our discussion, they are promiscuous. That means the signals from different cytokines or growth factors usually go not from only one JAK2 family member, but through two or three. You see the JAKs are associated with the receptors inside the cells. It's outlined here on the picture on this graph, and signal when the cytokine binds to a receptor. It activates STAT, so that's why we called this JAK-STAT pathway, and makes cells do whatever the cell is supposed to be doing. Exception to the rule that this is promiscuous signaling is the role of the JAK2 itself, specifically being associated with the receptors for erythropoietin and thrombopoietin. That means that in normal person, when you need to have a blood made, red blood cells or platelets, the JAK2 gets activated with erythropoietin or thrombopoietin attached to the surface, and the JAK2 is specifically active to make cells grow. This has a lot of implications for what we see in the clinic with the JAK2 inhibitors. If I'm to take the JAK2 inhibitor, I would have anemia and thrombocytopenia at one point in time. Depends on the dose. You push the dose higher, I'll develop more anemia and thrombocytopenia, and you too. So these are limitations to JAK2 inhibitors. Remember that when we come to clinical studies. So in 2005, we learned about this JAK2 V617F mutation that happens in about half of the patients that have myelofibrosis, and some have this with ET, and almost all of patients with PV. In that case, you do not need any cytokine to bind to a receptor. Mutation makes this enzyme always active. This is a tyrosine kinase. So no need for cytokine. It makes cells grow on its own. And the story in 2005 was something like chronic myeloid leukemia. We're going to inhibit mutated JAK2. We're going to eliminate disease. This is not chronic myeloid leukemia. It doesn't work like that. Has no resemblance to it at all. First problem was obvious at the beginning. Not everybody has the mutation. In chronic myeloid leukemia, everybody has it, and it's cause for the disease. Here, it is not the cause. There are many other mutations. This is just a partial list. Every other month, you have another mutation identified in another subgroup of myeloproliferative disease patients. By my last count, there are more than 20 of them. Not just JAK2 V617F. There are many of them, and in one patient, you can have multiple mutations or no mutations at all. In fact, this is a very interesting story. You see, each box here is one patient. So, for example, this one patient that we present here on the right upper corner has many cells that have a deletion 20q abnormality in cells. Some of these cells have also V617F mutation. Let's take a look at the lower left corner. This patient has two different clones at the same time. One clone with JAK2 exon 12 mutation, and then another one with V617F mutation. Look at the one in the middle at the bottom. This particular patient has multiple different cells with multiple different mutations, starting with the V617F mutation on one side. Some of these cells have chromosomal abnormalities and additional abnormalities here. You see that one patient may have multiple different cell types where we talk about genetic abnormalities. And so the bottom line is the JAK2 V617F mutation is just one of many, and it's not the cause for the disease. So this is a summary of what I was saying so far. Because of the other mutations that have been identified so far, we unfortunately don't have a very good wording to describe this. So that's why I put here multiclonal state, because the multiclones are identified in a single individual. We know now that the JAK2 mutation is not a cause for the disease. It is contributor among many mutations for disease existence. However, there is very clear evidence that regardless of the mutational status of the patient, regardless of what the patient has, everybody has dysregulated JAK-STAT pathway. This pathway inside the cells doesn't work very well. It's very active in one patient because of the JAK2 mutation, in another patient because of some other mutation. In many patients, we don't even know yet but everybody has high activity of the JAK-STAT pathway. Now, this particular slide looks very confusing, but it's important, so I'll guide you through it. You have here a possible JAK2 kinase description, how it actually looks like a structure. And in the middle here is where the site of the mutation is. You see V617A site. This is where the mutation happens. What happens when you have a mutation, the structure of the protein changes from blue to red. And the red makes this enzyme always active. Why am I showing this? Because all the JAK2 inhibitors that we have in the clinic, and there are about 10 of them, bind to the yellow port, to the yellow point here. They bind to prevent ATP, an energy source, to bind to the JAK2 enzyme. So it prevents the ATP binding. That's how it inhibits the enzyme. And as you can see, therefore, the JAK2 inhibitors are not specific for the JAK2 mutation. They are simply JAK2 inhibitors. That's why I started saying that in a normal person, if anybody here takes the JAK2 inhibitor, it will inhibit normal JAK2, and we will be developing anemia and low platelets as a consequence of on-target effect of the JAK2 inhibitors. So this is the summary of this introductory part. The drugs are not selective for the mutation. You do not need to test any patient for the presence of the mutation to treat the patient with the JAK2 inhibitor. It is not only for the patients with the JAK2 mutation. It works in everybody because everybody has high activity of the JAK-STAT pathway for different reasons. These are not selective for the mutation. Therefore, they benefit all the patients, regardless of the mutational status. On the other hand, we cannot really predict that we're going to eliminate disease because we inhibit normal hematopoiesis and everybody will become aplastic if you push the dose high. So the best that we can get with JAK2 inhibitors is very good control of signs and symptoms of the disease. This is a list of drugs that are still in a clinic, JAK2 inhibitors, at different point in drug development. As you see, there were 10 at the beginning. Some are not on the list anymore because of different toxicities that prevented their further development. As you know, the last one on the list, ruxolitinib, has recently been approved in the United States based on 2 phase 3 randomized studies as a first ever therapy for intermediate and high risk myelofibrosis patients. We'll talk about this a little more in detail later. How do we evaluate the efficacy of the JAK2 inhibitors in myelofibrosis? That comes from the common sense approach. When you see the patient in a clinic, as you do, there are 3 major problems listed here. About 80% of the patients will have a very big spleen. About 40% will have a very big liver. The lungs can be involved. Extramedullary hematopoiesis. Quality of life is generally very poor and gets poorer over time. Patients lose weight. The performance status goes down. They end up at home or hospice. Most of the patients, in my experience, die in hospice from slow death, body wasting, basically. And anemia, of course, is a problem. So on the other hand, we would expect a degree of myelosuppression, as I explained, because of on-target efficacy or inhibition of the normal JAK2 inhibitor. So let's take a look at the efficacy one by one. Let's take a look at the splenomegaly. This is the typical patient with big spleen. As you see, this patient always is losing weight. You see the ribs. This spleen is growing over time and limits patients' ability to bend, to walk. Patients losing weight and become hectic. This particular patient actually was in a wheelchair at the beginning. This is what happens on the therapy in most of the patients. It does shrink significantly the spleen, and it does shrink the liver in patients with big liver. It's not a spleen-specific drug. These are JAK2 inhibitors that reduce the proliferation of the cells and improve the symptoms. This is an example. I'm not showing you the best example. This is the typical example. Because look at the results of different studies. Here we have a degree of a decrease in spleen on this particular study with a drug called CYT387. Everybody was normalized to 0, and this is a degree of spleen reduction in each particular patient. Each bar is one patient. About 46% of the patient had about 50% reduction. By and large, almost everybody benefits, but to different extent. We still try to understand that, but by and large, everybody benefits. Another drug, SAR-302-503, which is in phase 3 studies at the moment around the globe, similar results. Most of the patients had response, about half of them had 50% decrease on intent to treat analysis. This is a very important slide. It has 3 points here. First, This is the spleen length on the y-axis. You see that the spleen length, this was in phase 1-2 study, the spleen reduces very rapidly. Usually what you see is within 1, 2, or 3 months at most. You see what happens to the patient. It doesn't happen later on. Everything happens within first few months. And it's durable. As you can see, it stays like that for a longer period of time. And as I said before, because these are not JAK2 mutation-specific drugs, patients with or without mutation benefit to the same extent. In no study so far was there any difference between the patients with or without the mutation. Again, you don't need to have only patients with mutation exposed to JAK2 inhibitor. Anybody can benefit. Now, for the purpose of clinical studies, we utilize the volumetric measurement of the spleen and liver, as is shown here, using MRI. This is something that is not obviously something to use in a clinical practice, but is important for proper evaluation of the benefits, because physical exam, as outlined here on the right side, can be misleading sometimes. We always use the tape, right? We call it splenometer. And sometimes it's more or less. It does vary from one person to the other. That's why the MRI is useful. And it was useful for approval of the ruxolitinib. This is the result of a COMFORT-1 phase 3 randomized study, blinded placebo-controlled study between ruxolitinib and placebo in a large number of patients. Again, everybody's spleen was normalized to 0, and going down is a decrease in the spleen size. Going up, it's obviously worsening of the spleen size, and each bar is one patient. As you can see on the ruxolitinib arm, almost all patients had a decrease in the spleen to different extent. It's not a magic pill that everybody takes the pill and the spleen goes away. In about half of the patients, there was at least 1/3 volumetric shrinkage. So people differ in terms of how they benefit. But by and large, except 2 patients in this particular study, had some degree of a decrease in the spleen. What about quality of life? We many times underestimate that and disregard that as something trivial. And it's not really very trivial at all. The patients really lose a lot of weight, they become hectic, they end up in a wheelchair. This is one example, again, not the best example. Just a typical patient who actually wanted me to show the pictures because he felt so much better. He lost 70 pounds and he was in a wheelchair in 2008 with very big organs, and this is him without big organs in 2011, gaining 40 pounds, about 20 kilos, and enjoying his life again. So how often does this happen? This is the result of that study that I mentioned before with CYT387. By and large, great majority of the patients would benefit in terms of improvement in the symptoms. I'm not talking about the spleen-related symptoms. I'm talking about constitutional symptoms. Spleen can shrink, and spleen responds better to a higher dose. Constitutional symptoms are not related to a degree of a spleen shrinkage. These are 2 different things. Patients without the big spleen also improve. They have less of a night sweating, bone pain, aches, pruritus, fever. They gain weight and walk more. It's not because of the spleen reduction. These are 2 different aspects of the benefit. The lower dose of ruxolitinib is very good for spleen. There is no real dose response curve for the spleen, for the symptom improvement. 10 milligrams twice a day is as good as 25 milligrams twice a day for a symptom improvement. These are the results from the SAR 302-503. As you can see, early satiety obviously would improve because spleen is going down, but fatigue, weakness, night sweating also improve. Constitutional symptoms. How about the COMFORT-1 study comparing the ruxolitinib to placebo? Ruxolitinib is in green, and everything below 0 is improvement. Everything above 0 and all the blue ones, unfortunately, are going up. This is placebo. In placebo, patients got worse. On ruxolitinib, patients got better. And look at these features that we have here, not just those symptoms related to the spleen, but night sweating, itching, bone muscle pain, inactivity. Everything improves in these patients. We also measure patients' ability to walk. On ruxolitinib study, phase 1-2 study published last year, or a year and a half ago actually, we used 6-minute walk test. That's a very simple test. You ask the patient to walk for 6 minutes, and then you measure how much the patient walks. Usually, patients, we learned that first, walk less than normal age-matched healthy volunteers, about 70 meters less. On therapy, patients get strength, they get energy, they gain weight, and they walk more. You see, after 6 months of therapy, in patients that we did this test, they regain the lost ability to walk. They gain weight. Some of the patients gain too much weight. That's a major problem, I tell you. Long-term toxicity, the most common is patients gain too much weight. The change in lifestyle doesn't usually follow the efficacy of the drug. The people have sedentary lifestyle. They don't feel well. Now they feel good. They eat more, but they need time to engage in activity and go out and enjoy life like everybody else. How about anemia? There are two aspects of our evaluation of the anemia response. One is to look whether patients that are transfusion dependent, by definitions that you define, become transfusion independent. The other one is actually to look at the hemoglobin, right? If the number is higher, that's good. Let's take a look at the first one. Red blood cell transfusions and response according to International Working Group response criteria was assessed in two different studies so far. Unfortunately, placebo-treated patients in COMFORT-1 study, the placebo-controlled blinded study, also respond. That tells us that we need to be a little bit better in defining what the transfusion dependency and independency is, a little bit more humble, and understand the problem that we are facing. And I hope that we will have modification of the criteria very soon. The other way is to look at the hemoglobin curves. And what you usually see, if you are at a good dose, that you do not see a myelosuppression much. But the real increase in the hemoglobin curve does not really happen. I haven't seen it in any study so far. And it makes sense, because we have here a drug that actually can inhibit the production of the red blood cells because of inhibition of normal JAK2. It would be very hard to expect red blood cell count in general to improve. There are exceptions. We don't understand that. We look at those, but by and large, red blood cell count does not improve. What are the other benefits? Are listed here. As you see, we control the signs and symptoms of the disease. Organs shrink, people gain weight, walk more, symptoms go away. We don't have a real change in the bone marrow. This is the disease that is being now treated with the medications that control signs and symptoms, but it does not eliminate it. What are the side effects of this therapy? Ruxolitinib is on the market in the United States. The main problem at the beginning is anemia and thrombocytopenia, on-target toxicity, like I explained at the beginning. In about up to a quarter of the patients, the dose needs to be adjusted. People do not get off ruxolitinib for anemia and thrombocytopenia. That's unusual. In COMFORT-1 study with 300 patients randomized, only one patient on ruxolitinib arm stopped for anemia and one for thrombocytopenia. The same as placebo. You adjust the dose. Others have different profiles, and this is actually where you see a major difference. Toxicity profiles differ. That usually limits how much you can give, for how long, and what is the ultimate benefit. The others are in different clinical studies. What happens if you stop the JAK2 inhibitor? This is from the COMFORT-1 study. Patients were filling out electronic diary every day at home, how they feel. Their symptoms were normalized first at the baseline to 0, and the symptoms were improved on therapy to 25 to 30%. We are talking about 40 patients that had to stop the therapy at one time for different reasons on ruxolitinib. What happens is, as you see here, within 7 days, symptoms go back to baseline. It controls signs and symptoms. The symptoms would return to baseline. It doesn't harm patients in terms of worsening their situation from baseline, but it does allow symptoms to return to the baseline. It is better usually to taper the drug off if you need to stop rather than just stop it, because within a week patients come back and say, oh, I feel so fatigued again like at the beginning. And the spleen can return too, not usually in a week, but in 2 or 3 or 4 weeks. So compliance with the therapy is very high, I can tell you, because people tell you, I didn't take the drug for 4 days, I feel so bad now. Are there any serious adverse events when you stop the drug? Very popular question. I put this slide up. So there were about 50 patients that stopped the therapy on ruxolitinib and about 50 on placebo. Serious adverse event, 3 cases on each arm. No difference of significance between placebo and ruxolitinib. What about side effects then? We said hemoglobin and platelets are target of this drug. About 45% of the patients on ruxolitinib arm had grade 3 or 4 hemoglobin at any point in time on the study, versus about 20% on placebo. So about 25%, as I said before, about a quarter of the patients may have anemia or thrombocytopenia requiring dose adjustments, not really discontinuation of the therapy. The most important part for me as a practicing doctor is at the bottom of this slide. The number of patients that discontinued ruxolitinib due to side effects was the same as the number of patients that discontinued therapy because of placebo. So that tells you that the drug is pretty safe. So in summary, these JAK2 inhibitors and ruxolitinib now being on the market in the United States as the first approved therapy for myelofibrosis are not selective for patients with mutations only. That's probably the most important message. They do different in their toxicity profiles, which will really define them better. And we see significant reduction in signs and symptoms of the disease. But the ultimate question is whether we can actually improve the survival of the patients. So moving from just a palliation to really something that is an ultimate question that the patient has when the patient comes to your office. Usually my experience is that the second question after first question being what myelofibrosis is, the second question usually is how long I'm going to live. Not too long, unfortunately, but let's take a look at efficacy in terms of prolonging life. This is the update that was presented at ASH from phase 1-2 study of ruxolitinib-treated patients at MD Anderson, 107 of them. Average follow-up is about 3.5 years now. We control these patients with a historical matched control from 4 different large databases. Patients had the same characteristics. You see the significant difference in survival. That's a retrospective analysis. It can be dismissed very easily. It's not randomized, it's not prospective. This is the result of a prospective analysis from the COMFORT-1 study. Placebo-controlled, you can object to that. That's how it was designed. It was placebo-controlled, randomized study between ruxolitinib and placebo with the crossover. Average time to crossing over from placebo to ruxolitinib was 41 weeks. Only 2 patients were still on placebo at the time of this analysis, and you see statistically significant difference. So it seems that by controlling signs and symptoms, people actually live longer. Why would that be? Because they, by and large, die from the worsening of the disease itself. Only about 20% transform to acute leukemia. Others suffer from worsening splenomegaly, worsening liver enlargement, worsening pulmonary hypertension, and die slow death from body wasting. We reverse these things or control progression. So can JAK2 inhibitors prolong life? It seems yes, from retrospective and prospective analysis. These are preliminary results, more to follow. With that, I will conclude my presentation, and I'm open for questions. Thank you very much.
Any burning questions? Because we'll come back at the end for...
Eliminate fibrosis.
It does not eliminate fibrosis. We were following patients on ruxolitinib study. This was the first ever phase 1-2 study. First patient was enrolled in June 2007. Fibrosis does not go away. It doesn't change. It doesn't get worse, though, but it doesn't get better. So we need combination studies. This is the next wave. We have studies underway with agents that would up the result with the JAK2 inhibitors in terms of fibrosis, perhaps, like a long-acting interferon that can do that, with Revlimid that was reported anecdotally that can do that, with histone deacetylase inhibitors, with HDAC inhibitors, mTOR inhibitors. There are a number of studies that you will see, some of them already underway, where there is another agent added on to a JAK2 inhibitor. And in everyday practice, how to deal with anemia, which doesn't get better. Adding on another agent, testosterone-like medication like danazol, maybe short course of prednisone for 3 months. Anything else that can be combined, I think is useful to try. There is no clinical experience with combinations. It's being studied. But how do you deal with that in everyday practice? You have to do something. So combination strategies, whatever your choice is the way to go. Just because patient already has anemia, thrombocytopenia, that does not prevent you from targeting 2 other factors, bad quality of life and the spleen. At least you manage 2 out of 3 clinical problems, spleen and bad quality of life.
Okay, thanks very much. Good presentation.